So welcome everyone to the Special Populations Core 2023 seminar series of the New Jersey Alliance for Clinical and Translational Science. Thank you for joining us for today's presentation. We're very excited to have Dr. Nathan Link of Rutgers University Camden with us to discuss incarceration, health, and the life course. Before we jump in, if you have any questions during the presentation, please feel free to use the chat and we'll either get to them during the talk itself or when we have time for Q&A at the end of the presentation. To get us started, I'm going to turn it over to Jim Lloyd, who's a research specialist here at the Rutgers Center for Health Services Research, to introduce Dr. Link. So Jim, over to you.
Thanks so much, Kylie. Professor Nathan Link is a criminologist, associate professor, and director of the graduate program in the Department of Sociology, Anthropology, and Criminal Justice at Rutgers University Camden. He's also affiliated with the Health Science Center and the graduate program in Prevention Science. Given his background in social work, he aims to create knowledge that can improve both public policy and the lives of those in contact with the justice system. He primarily researches issues in corrections and sentencing, including financial sanctions and debt, prisoner reentry and desistance from crime, mental and physical health, and crime recidivism control strategies. Professor Link's research has been supported with grants from the National Institute of Justice, Arnold Ventures, the William T. Grant Foundation, and the Drug Enforcement and Policy Center at Moritz College of Law. His work appears in a variety of refereed outlets, including Criminology, Justice Quarterly, Social Science and Medicine, Criminal Justice and Behavior, the Journal of Developmental and Life Course Criminology, the Journal of Experimental Criminology, the Journal of Offender Rehabilitation, UCLA Criminal Justice Law Review, and Health and Justice. In 2018, the Academy of Criminal Justice Sciences recognized one of his articles with the Donald McNamara Award for Outstanding Journal Publication. And in 2021, he was a recipient of the Chancellor's Award for Outstanding Research. We are very excited to have this presentation from Professor Link right now. And Professor Link, over to you.
Okay, thank you so much for that introduction, Jim. That was too nice and made me sound more scholarly than I actually am. Can you hear me okay? Did I share my screen properly?
Here we go.
Okay, great. Well, thanks again for having me, and thanks to Kylie for organizing this and for the invitation to be here today. I think this core seminar series is fantastic, and I definitely watch some of the ones that you have recorded on YouTube, and so I'm glad to be here, and thanks for doing what you do. As Jim said, I'm going to be talking about health, incarceration, and the life course, which is one of my two main lines of research, in addition to studying the financial sanctions that people face when they're arrested and processed by the justice system. The two research lines do connect because financial sanctions like fines and fees have an impact on health, especially mental health. But I'm not going to be doing that connecting right here. I'm going to stick with my more health-related lines of work. Okay, so to give you a sense of what I study, I am a criminologist, which means that traditionally speaking, we study offending and system and societal reactions to offending. But the main areas that I like to focus on are what we call the collateral consequences of a criminal record or an arrest, and then studying the transition home from prison to the community, because we know that's a fraught process that has many barriers and many hazards along the way. When I talk about collateral consequences briefly, I'm talking about these sort of other effects, legal or social, that arise from having a criminal record, such as being barred from employment, not being able to vote, not being able to get a bank account or a credit card, not being able to get licenses for all kinds of things. All of these sort of barriers that prevent people from being able to integrate properly back into society. And theoretically speaking, I often leverage life course paradigms. And I know life course paradigms are, excuse me, popular across disciplines, right? It's used in sociology and epidemiology and developmental psychology, etc. But I noticed some differences in the way life course theories and perspectives are used across these disciplines. And namely, one of the biggest differences is that in criminology, we don't spend a lot of time, or I would say any, on looking at the impacts of health. in the life course, really either as an independent variable or as a dependent variable. What we're trying to do in this line of research is both theorize and then test where health, both mental and physical health issues, might fit into criminological life course paradigms. And as I'll explain in the rest of the presentation, we think that there's a number of reasons why it should play a much more prominent role. We do know of a number of studies, mostly out of sociology, that do document the impact of incarceration on poorer health outcomes. But what we are trying to argue now is that you can flip it, and there's a number of reasons why health issues ultimately increase the likelihood of incarceration.
Nate, just as a kind of to get a sense of the scope,
Right.
The huge array of issues about imprisonment of people with serious mental illnesses following deinstitutionalization with mental hospitals. How do you sort of is that kind of subsumed under your broad concept of health, or are you sort of creating a separate space from that kind of literature?
No, I would say that our data sort of capture that historical process. Further on in the presentation, when I get to the sort of breakdown of some of the variables, you'll see that we do measure mental health. We don't do it in a comprehensive kind of way, because there's obviously a number of mental health conditions that we could be measuring that can be tied back to deinstitutionalization in the way that we didn't react properly to that. So that's one of the reasons that I think that this kind of work is necessary, because we have so many people leaving incarceration with mental health problems, so many people going into prisons with mental health problems.
Oh, nice. So I see that you have published specifically on this. That's great.
Yeah, so these are the three studies that sort of are in this line that I'm going to be talking about. And the first one there is I guess they're not in chronological order, but the first one is where we sort of introduce this concept to our field in particular. And again, I'm talking to a bunch of people who are interested in health. This may not sound surprising that health would matter for prisoner reentry, but in criminology, again, as I said, our life course paradigms don't really capture that, don't really appreciate the value of the impact of health in someone's life. Excuse me. And so the first paper is the sort of the original paper where we present this sort of line of thinking. And then in the second paper, we apply this to a sample of juveniles because we think that processes could be similar, though a little bit different among juveniles. And in the third paper, that's the one where we apply it specifically to a sample of people with serious mental illnesses. That actually is the paper that I'm not going to be talking about in this talk, because I think for the sake of thoroughness, I can't get through sort of three angles in the amount of time that we have. But I'm glad to talk about that one later on in the Q&A if we want to talk specifically about how some of these issues might play out specifically among people with suffering from serious psychopathology.
Great.
Okay, so I'm going to talk a little bit about the theoretical background that is sort of driving our work in this area. I'm going to do my very best to not use any academic jargon. I try not to as often as I can, but because we operate in these silos, if I do use a word or a concept or something that's unfamiliar, please let me know, and I'll just try to use simpler language. But as I said, we do know that incarceration can have an adverse impact on health conditions. We know this from a number of studies. And we know that it's especially true for infectious diseases, excuse me, for tuberculosis, for COVID-19, things that are transmitted easily in places that are full of human beings in close quarters with little ventilation, right? So those kinds of health conditions are dramatically exacerbated. We also know that stress and blood pressure and things like that are dramatically increased by the exposure to incarceration. Incarceration being such a stressful, kind of dangerous kind of environment. We know that these kind of adverse effects on health are especially strong in the US. We know that from a paper that Chris Wildeman did, showing that the health impacts of incarceration aren't necessarily there in other countries, but they are in the United States, which I think, again, speaks to more evidence of the pretty inhumane ways that we operate corrections in this country. We know that mortality risk is extremely high right after people who are released from prison. This is related to substance abuse, to overdoses. We know it's heart disease is implicated right when people are released. Again, it's a very stressful transition home when you are wondering, where am I going to sleep? Where am I going to find money to pay for everything? I can't sleep in a public park because probation says I can't. All of these things are very stressful and contribute to high mortality rates, I'd say, in the first month after release from incarceration. We know that these health effects can develop and sort of compound over time in the life course. So for example, if someone comes out of incarceration and they're unemployed, which is common, they might not have access to healthcare because we tie healthcare to employment so much in this country. So they might go to the ER, and those bills are really expensive. So you can see how this incarceration sort of builds over time and creates these other barriers that can be tied back to incarceration. We also know that those in contact with the justice system are more likely to have health problems in the first place. So sort of getting at the point that was just made about people with mental illnesses being pushed toward incarceration ever since deinstitutionalization. But we do know that even among those people, incarceration tends to make things worse, especially in places that heavily rely on really kind of controlling measures such as solitary confinement and things like that. I shouldn't make the case too strongly that the link between incarceration and health is always in a negative direction, is always bad for health, because the literature is a little bit unclear, I would say empirically, because sometimes there are cases where health is actually protected by incarceration. And in some cases that might be access to some kind of health care. But I think what's driving it more is that for people who are highly involved in violent crime, such as gang members, a stint in jail or prison actually does kind of protect them, because these individuals are at such a high risk of being a victim of a homicide that you know, being secluded from society actually is a little bit protective in those instances, which is a pretty sad kind of reality. Okay, so again, in criminology, we have these sort of life course theories and these reentry ideas that we have correlated with recidivism. And again, recidivism being the main kind of concern for criminologists, the main outcomes that they tend to look at. So we've identified these kinds of things that happen in the life course. A lot of these would be familiar based on Sampson and Loeb's work. But we know that family and marriages, and not just marriages, but strong relationships are correlated with less offending, that is with desisting from crime, meaning people stopping offending over time. There's a number of reasons why that could be the case. If you have a strong family, you sort of have motivation to do well, to not get in trouble again. Families are also sort of demanding on your time, right? I'm a father to 2 little kids, and that structures my time in a way that's unbelievable, right? And so that is a sort of controlling effect there, right? We talk about family as being a really strong source of informal social control in criminology. The sort of inverse of that is that we have studies showing that when there's conflict in families or when family support is low, that people later in time, are more likely to get involved in criminal behavior. So again, showing that strong families matter, and weak family ties and family bonds isn't great from a life course perspective on the recidivism question. Okay, so the second big one is employment as a turning point, right? There's probably a number of reasons why employment would keep people away from crime. One, you have money, you have a job, you have a certain identity, right? You're a certain kind of worker now. But then again, in criminology, we talk a lot about opportunity, and having employment, especially full-time employment, structures your sort of routine activities, structures your day-to-day in a way that just makes getting involved in crime or substance abuse a little bit less possible. And a number of studies have sort of documented the sort of benefits of employment in this regard. And then economic hardship, especially in the reentry literature, is identified as something that puts people on a path toward all of these negative outcomes for obvious reasons. If you can't pay for your daily needs or your health needs, then the struggle just gets even worse. In criminal justice, again, I'm going to connect this with my other line of work. It is very, very common to come out of jail and prison with thousands and thousands of dollars in debt that you owe back to the courts. And probation and parole is sort of in charge of collecting this debt. And there's serious consequences if you don't pay it back, including rearrest and reincarceration in some places. So that's obviously not something that is going to be a positive thing in the lives of people trying to transition home. Okay, so in order to connect these kinds of literatures that already exist, essentially what we wanted to do is, theoretically, does it make sense that health conditions, both physical and mental health conditions, would have an impact on being able to achieve some of these life course or reentry outcomes that we know are protective against crime? Because if they are, then we can draw out a sort of fuller model that shows, okay, look, these health conditions ultimately cause crime and reincarceration through this mechanism of decreasing the chances of employment or harming family relationships or exacerbating economic hardship. And we think theoretically there's a bunch of clear reasons why we might expect this, right? If you are experiencing mental or physical health issues, it may be very hard to get to jobs to even apply to them. If you do get a job, it may be hard to get the transportation needed to get to that job. It may be hard to succeed in that job, depending on what the job is. This is especially true for physical health, I would say, because we know that a lot of people who were incarcerated are sort of relegated to these jobs that require a lot of physical labor, right? So when you think about landscaping or warehouse work or construction, these are demanding physically, and many former prisoners are only able to find work in these kinds of industries. We know that people who leave prison are often very reliant on family members, often the women in their lives, and that could be spouses, moms, grandmothers, and for very sort of tangible needs, such as a place to sleep, money, food, things like that. And so we can sort of theorize that people who rely a little bit too heavily on these family members, that might cause a strain in the relationship. Anecdotally speaking, I've heard that from a number of people saying, look, I support my loved one and I want them to do well, so I am giving them money, where I can here and there, but that's starting to cause a strain on my bottom line as well. And so sort of disagreement can sort of arise, we think, in that context. And then health and economic hardship, we think, are related, because treatment is very expensive. Co-pays are a lot. As I said, there's fees for everything in criminal justice now. and it can be very difficult to sort of manage your expenses. So this is the kind of theoretical link that we're trying to make in order to make the case that health conditions probably impact recidivism and reincarceration. So with that sort of in mind, those literatures kind of motivate our questions here, which are, do both dimensions of health, physical and mental, affect key life course processes and reentry outcomes? And does health impact recidivism directly and indirectly through its impact on life course variables and reentry constructs? So as I said, I'm going to talk about two of the studies that we've done in this area. And the first is a study among adults. And the data come from this, what's known as the Serious and Violent Offender Reentry Initiative. This was a multi-state, multi-year, federally funded project by Pam Lattimore and Christy Vischer. The sample comes from 12 states across the US, a sample of about 1,700 at baseline, which was measured about a month before people were released. This is considered a high-risk sample, meaning the participants have histories of substance use, unemployment, and most of them have multiple arrests on their records. The interview data, or I should say survey data, were collected over 4 time periods, 3 months after release, 9 months after release, and 15 months after release. And so this does represent the sort of biggest study of prisoner reentry in the United States to date. Before I get into this sort of key variables that we looked at using this data, I will mention that the SFORI data has a certain number of limitations, and I'm happy to talk about what those are later on. But I'll just say up front, it's very hard to study the reentry process using large samples of people because of numerous things, but especially that people are hard to follow. This population is particularly hard to follow over time. Okay, so looking at the data, we use these variables as sort of concrete measures that sort of get at someone's physical health status. We also used other variables such as the sort of commonly used self-reported physical health scale that ranges from poor to excellent. But we like the idea of using this sort of concrete scale in our main analysis. We used factor analysis to create these measures. And I won't jump into factor analysis or structural equation modeling, but I'm glad to answer any questions later on if there are about how that works. And then we also measured depression. So again, there are other mental health diagnoses that we certainly need to dive into, but depression is what we examined in our first sort of foray into work into this area. So we used the CESD scale produced by Radloff and others from several decades ago. And it is a scale of, I think, something like 20 plus items. I can't remember offhand. And again, we used factor analysis to try to create the most sort of defensible scale that we could. And then thinking about these sort of life course and reentry variables that I talked about, we measure employment, which is a binary variable, which is yes, if the people reported having legitimate employment. We measured family conflict using these 3 items. And again, that was created using a factor analysis. And then financial problems was measured with a binary variable indicating if someone had a need for financial assistance. Our key outcome variables were self-reported crime. We made a variety measure capturing a number of different kinds of crime. And then we got reincarceration data from official records from state agencies and the FBI. When I say we got it, I should say the SFORI researchers got it from there. Okay, so this is the conceptual model that we sort of built over time that sort of gets at our theory, our idea that both mental and physical health conditions are bad for the desistance process. That is, they lead to crime and they lead to reincarceration. So again, theoretically, we think that there are some of these key links here between depression and family conflict, depression and employment, and then physical health problems and employment, physical health problems and family conflict. And from there, I mean, the sort of part of the model that's in the middle and to the right side, that's sort of already been established by life course literatures and reentry studies. So the real contribution, I think, is kind of just like pushing all of this together and making the case that these health conditions harm these life course achievements and statuses.
So if you had an intervention of some kind, let's say a peer navigation intervention, then that could become an additional box of something that was potentially actionable in this study?
Definitely. Yeah, I actually talk about that on my last slide. So if we could circle back to that, that would be great.
Yep.
Okay. Okay, so these are essentially a summary of the main findings. Again, the ovals indicate that these are latent factors, and the rectangles mean they're observed factors. Again, I won't get much into that unless there's questions about it. But first, we see a pretty strong impact of physical health problems on depression, which I don't think is surprising. Even when I'm happen to have a physical health problem, I mean, it gets me down, right? I can't go out and do the things that I like to do. We see a negative impact of physical health problems on employment, meaning as your physical health problems increase, the likelihood of you finding employment decreases, which is sort of expected. And then in terms of depression, the higher your depression goes, it correlates positively with increased family conflict. So we see sort of mental health conditions and statuses making family relationships a little bit more strained. This link between employment and family conflict is a pretty strong one in a negative direction, right? So if you're unemployed, your family conflict is increased. Employment has a negative relationship on financial problems, which is so obvious, but again, something that we modeled. And then this is the sort of link between employment and crime that get at Sampson and Loeb's work, showing that if you're employed, you're less likely to get involved in crime later in time. And then here we again find more evidence that as family relationships break down, people are more likely to get involved in crime later in time. We see a relationship between crime and financial problems, although it's in a direction that we didn't quite theorize, meaning that if you're involved in crime, your financial problems go up. We would have theorized it the opposite direction, and I can talk a little bit more later if people have questions about why that might be the case. And then finally, if you have financial problems or if you get involved in crime, that increases your likelihood of reincarceration. So generally speaking, I think the findings are pretty self-explanatory and expected. Excuse me, sorry. And I think that the contribution here is that physical health problems decreases employment, and depression increases family conflict. Okay, so that was our study about adults. And before I jump into implications and next work about that, I want to present our more recent study that we published that looks at these kinds of problems and mechanisms among young adults, people who are 18 to 25, because we think it's fundamentally kind of a different sample, and that some of the issues and some of the health concerns are different among this age group. So, again, we're coming from a life course perspective that sort of looks at the processes of, turning into an adult around these years. And it is a sort of really critical period because you're sort of figuring yourself out, who you are in society and what you're going to do. Are you going to start a family? And this kind of period of like role exploration is pretty delayed in this country compared to some other countries. And so it's a sort of longer period where people are sort of figuring themselves out. It also is a really important sort of period to study criminologically, because we know based on the age crime curve that this is the sort of time period when that sort of separates people who might have gotten involved in a bit of delinquency growing up, but then sort of moved on and became productive in these other ways. And the population of people who, you know, Terry Moffat calls life course persistent offenders, who you know, sort of remain involved in criminal activity for a much longer time. And so we're trying to identify what is it about some of these people in this age group that allows them to desist, that is sort of exit the, you know, the sort of criminal career. And so when we're thinking about this kind of age group, a lot of the literature focuses on the concept of psychosocial maturity, meaning sort of that like people develop this sense of autonomy in this during this time frame. They develop these feelings of control, they take initiative, and they become a little bit less dependent on family and others for, say, financial and other kinds of tangible needs. They develop a stronger sense of identity, who they are, what their goals are, what they would like to, you know, do, who they would like to be. And they develop a sort of orientation to work. You know, what would I like to do? How am I going to spend my time? Because, you know, I'm growing up and I need to get out and, say, go to grad school and do something or something like that. And so again, this concept is very important in the developmental literatures and has shown to be very predictive of lots of different outcomes, including offending and desistance from crime. So people who develop this sense of psychosocial maturity a little bit earlier are more likely to leave the sort of realm of criminal offending earlier as well. And we know that, you know, similar to other kinds of cognitive processes, that psychosocial maturity continues to develop in the brain up until about age 25. Again, so it's sort of a longer time period. And so we're interested in whether this sort of construct is affected by mental and physical health conditions.
So Nate, when you use this as a conceptual model, do you also need to sort of incorporate boxes for the peer group, what peer groups people select into?
Can you expand on that question a little bit?
Yeah, well, if you sort of take a you know, biopsychosocial perspective,
Yeah.
This is a little bit more on the psychological side, and then on the social side, these kind of developmental things interact with who you choose to, who you end up associating with. And if you associate, this is the old deviance scholar in me, and deviance theory, and that becomes, this is kind of an interacting process between the developmental and the social, where people select into into deviant peer groups and then get drawn into criminal careers.
That's right.
So,
that's right.
You know, and
Yeah.
I'm sure that in your work you reference these kind of things, but just, you know, sort of as, you know, what do you start with when you write down what the conceptual model is?
Yeah, no, that's exactly right. You know, being a criminologist and someone who also comes from a sort of deviance background, like I'm sort of biased towards those as opposed to the more psychological and developmental angles. So we definitely control for things like that, including number of peers who have also been arrested, and,
Right.
and sort of trying to get at, is this a social thing, or is this a brain thing, or is it kind of both? Things like that. So the reason we sort of incorporated psychosocial maturity so strongly into it is that essentially the literature kind of demands it. They say, look, this is so strong. We need to focus on psychosocial maturity. So we do that, but then we sort of control for these other things that also matter, as you point out.
The interesting thing, and I imagine you think about this from time to time, when you think about sort of the contemporary literature on adverse child experiences, and just the sort of the cumulative load of trauma and stress is, and I don't know how easy this is to develop, but arguably young people who have had fewer opportunities to actually develop their executive function due to those stresses may actually be behind in the development of executive function. So that would be, it would be interesting if, from sort of in contemporary experiences, you could somehow try to capture that. And of course, a lot of people would like to get pretty fMRI pictures and show that there's less myelination in these kids and so forth. But it's just the sort of body keeps the score kind of idea that it affects everything. These stresses affect everything in development. I bet you would find that many of these kids were low birth weight right from the start.
I would totally agree with you. And I actually have a collaborator who has a cohort data set of people who were followed for many years. And the sort of initial data that were collected were on their mothers when they were when they were pregnant. And so it becomes very complicated to sort of untangle, well, which came first, and things like that. But that's something that we're looking at in a separate project that I'd be glad to talk to you more about later
onward.
Yeah, later on. I feel like I'm going a little bit too slowly, so I'm going to run through a couple of these slides and present more data a little bit more quickly. So essentially what I'm trying to say is that we think there's good reason why both depression and physical health problems could impact psychosocial maturity, right? So again, we're getting back to the social, the health, the sort of lived things that could potentially affect this developmental process. This is particularly important at this point in time because mental and physical health issues are a problem among young adults, which has been very much exacerbated by the COVID-19 pandemic. And we also know that the sort of age group of like 19 to 30 something is also the least insured of all age groups as well. So also the most vulnerable in terms of not being able to address some of these issues. And so here we make the case that theoretically it makes sense that health could impact psychosocial maturity. And so, if you think about psychosocial maturity having to do with self-reliance and identity and self-esteem, say if an individual has depression, they may be much less likely to develop this sense of, independence and identity and self-reliance later on because of the, mental health issue that they're suffering. And for physical health as well, I mean, if work orientation is a key sort of component of psychosocial maturity, you could imagine that people who are in poor physical health, their sort of development in this kind of way might be stunted because, work may not be a possibility for them. So we think that there's some sort of connections here that make sense theoretically. So our research question is, does poor health stall psychosocial maturity development? which in turn reduces normative desistance from offending and substance use. So again, this is our sort of path model that is much simplified here, but this sort of summarizes what we think could be going on. So again, we have physical health impacting depression. Physical health, I should say this is measured as a self-reported scale, where higher on the scale means better health. So as your physical health goes up, your sort of psychosocial maturity later in time probably goes down or sort of develops less quickly. That if you have depression, that sort of decreases psychosocial maturity. And then in turn, we're sort of, again, relying on this literature that's already there, that wasn't developed by us, but is pretty strong, that says that psychosocial maturity is strongly related to offending and substance use. So to examine sort of these ideas among this sort of different populations, we relied on the pathways data, the pathways to desistance study data. And this followed 1354 people who were adjudicated for serious crimes, about half in Philadelphia and half in Phoenix. And they were followed for 7 years. So the sort of ages at baseline were 14 to 18. So if you sort of add 7 years to both of those, you're really capturing this kind of critical period, between 18 and 25 that we're talking about in terms of development. So these are how we measured our key variables. I think I'm going to gloss over this for the sake of time. But basically, our hypotheses turned out to be what was shown in the data. And so physical health, as it goes up, it does increase your sort of level of psychosocial maturity. And as your depression goes up, your psychosocial maturity is lower later in time. Both of those things in turn influence offending and substance use. So we're trying to make the case here that physical health and mental health increase offending and substance use over time through this kind of mechanism, which is a little bit different for younger people, this sort of psychosocial maturity construct that is talked about so much in certain fields.
You might also, if you're, when you're sort of talking about this, the mental disorders among youth and young adults that are the diagnoses that are associated with maladaptive aggression, which which include there's more and more diagnosing of those conditions, and those kids often are on a pathway to trouble. In foster care, the proportion of kids that have those disruptive behavior disorders, they get diagnosed with conduct disorder, they get diagnosed with bipolar in many cases. So those externalizing, depression is sort of your classic internalizing disorder. But you might also sort of draw it with a box for the externalizing disorders, because those are often the ones that lead people into juvenile justice and then adult justice kind of, and it's always sort of, the classic joke is you kind of have to decide whether a given syndrome is mad, bad, or sad, and they get labeled. You can easily go from, for example, sad or mad to bad.
Right.
But when you think in terms of how you sort of could align this with the way that mental health researchers divide things up, oftentimes it's the externalizing and the internalizing. So you could just sort of think about creating a space for that in the diagrams, and maybe thinking about trying to capture some. I'm not too expert on what this kind of standard screeners are for the externalizing disorders, but I'm sure they're out there.
Yeah, yeah. No, I mean that's a fantastic point, and one that I sort of allude to in the future directions slide. One of the reasons that depression was sort of focused on specifically, unfortunately, is that this was a sort of criminological study, and
Yeah.
uh, we did not have wonderful measures of lots of these conditions, in part because of who designed the study, and it's a fantastic study. So I don't want it to sort of get out there. But also, this is like a very disadvantaged population, and so when you run a frequency on like how many people have bipolar disorder or something, and it comes back as like 5 out of 1,300, you're like, well, I know that's not true. And the sort of diagnosis and access to healthcare is so
Right.
unfortunately
Right.
minimal. But yeah, it's a really sort of interesting idea, that we want to try to get at moving forward.
And my apologies for slowing you down.
Oh, no. It's been that's been on my mind for a long time, and it's kind of frustrating that it's hard to find data that can sort of speak to those different kinds of symptoms, or conditions with different symptoms. Sorry, my printer just made a lot of noise. I have to turn it off real quick. Okay, so I'll run through these fairly quickly. I'm aware of time. We have about 10 minutes left. But uh, I'm sort of preaching to the choir here, but in my field, I'm trying to make the point that health really matters. It matters for a number of reasons, but it also matters because I think there's a lot of reasons why health is predictive of a lot of things that criminologists care about. And so we have been sort of pushing this idea, and it's been gaining a little bit of traction, I think. And so we are sort of optimistic that it's going to take root some more. So for policy, happens to be one of the sort of lines of research where the policy implications sound great, right? Because they sort of align with things that I would like to see anyway, and things that society should be doing anyway. But I really do think there's an opportunity here to address health conditions, right? If we are going to incarcerate people and incarcerate so many people, perhaps we can use that as an opportunity to sort of get them involved in interventions, say some of these peer navigator programs, or really anything that we think might be able to sort of mitigate some of these hazards related to these health conditions. Generally speaking, there's a lot of things that need to be improved about prison climate and what happens in prisons. Diet is a big one. We know that a lot of the food that is fed to incarcerated people is really not great. It's very high in carbs. It's not the best kind of thing for the microbiome, I'm sure, because it's short on fruit and vegetables. Physical activity interventions might be useful both during incarceration and in reentry. The possibility of sort of educating people on health while they're incarcerated could be explored. I think we should reduce barriers to medical treatment. So again, this sort of ties back to my other line of work. Yes, people can get some kind of care when they're incarcerated, but they often pay for it, and it can be a lot, especially if you're not making any money or you're making $1 a day at your in-prison job. And then I think trying to make a more seamless transition in terms of getting people linked up with Medicaid, so that there's not a gap in their sort of medications, is critical. And I think there's some people in the social work department at the University of Missouri who are doing some pretty awesome work in this area, trying to figure out ways to address that gap, using lots of funding sources. And then these are just examples of how big this sort of task is that we have at hand. because our prisons really are they remain very inhumane. And we see headlines like this all the time. And these kinds of things obviously shouldn't happen for many reasons, including that it's illegal. But these are the kinds of things that are really harming health for people who are leaving these kinds of institutions, right? We also shouldn't see examples like this where people are abused in this kind of way and really malnourished. And then we also shouldn't forget that these kinds of things happen in our backyard as well, right? So the Edna Mann Women's Prison that is supposedly being shut down has a lengthy history of all kinds of abuse and mistreatment. And these kinds of things certainly impact people's health throughout their time and in the reentry process. Okay, so quickly to future directions, we want to sort of unpack some of these dynamics in a little more clear of a way. We really think these first 3 studies are kind of scratching the surface on this idea about how health sort of relates to some of these other outcomes that we're concerned about. So we'd like to, as Stephen said, try to figure out how to get some better measures of some of these conditions. We are proposing, right? We propose that the mediators between health and crime and incarceration are different for adults compared to juveniles, right? We said that employment and family conflict might matter more for adults, and that for juveniles, it's psychosocial maturity. But that's not to say that these are the only mediators. There's probably a lot of things that we haven't figured out that are connecting health conditions with some of these system involvement outcomes. So we want to sort of figure that out, again, using different samples of different populations, some of which I list on the slide here. So we know from the research that incarceration can harm health. We know from some of our studies that health can increase incarceration. So, if we could ideally get some of these, long-term longitudinal data to see how these sort of processes work over time to, in a reciprocal kind of way, I think that would be a really sort of valuable study that would show how incarceration is one of these other things that is exacerbating health disparities in a pretty major way. And then finally, we have done these 3 studies using observational data. And again, getting to one of Stephen's points, we don't know what interventions might sort of be able to sever some of these links between health conditions and finding yourself back in jail. And so, in the peer navigator idea sounds great, but I think there's just a number of different ideas or directions we could go in that could theoretically, improve mental health conditions and physical health problems. The idea that the problem is trying to figure out what those interventions are and then test them in the real world, and then sort of ultimately get at the question that I put at the bottom, which I feel like more and more animates all of my work these days, which is what kind of interventions work for whom and under what conditions. And at least in the literature that I sort of float around in, I mean, I think we're like a really, really long way away from answering that question. So again, I think this kind of work is kind of scratching the surface of what kinds of health interventions would be useful to keep people away from the justice system. So
thank you so much. Oh, this is perfect. We have like 5 minutes for people to ask questions, and if people can just jump right in.
And I should say quickly, if I took too much time, I put my email there, so I'd be happy to talk to anyone over email as well.
Thanks for your presentation, Nate. That was really interesting and really aligns with the type of stuff I'm interested in and that we've been part of what we've been working on in our center. I just had a question. In the last set of results you presented, where you looked at the relationship between health problems and substance use and crime mediated by psychosocial maturity, was that the term?
That's right.
Yeah, did you look at all at the direct relationship between health and those? Because I just wonder, like, if there's still more variation there that's not accounted for, because I was thinking about what else might drive substance use in that age group as it relates to health problems.
Yeah, that's an interesting question. I know we definitely looked at direct impacts in the study among adults, and we didn't find a link there. And I'm pretty sure we did that as well in this study. I can go back and look, but I think we didn't find that to be significant. If we did, we definitely included that in the sort of summary of results. But yeah, I mean, it makes a lot of sense to me that that link would be there, right? If you're suffering from depression, that substance abuse later in time would be increased. But we didn't find that in this model.
Thank you.
You're welcome. I should say that the substance use is kind of one of the weaker points in some of our models in this area. And we're trying to figure out a way to better incorporate and make substance use a little bit more prominent in some of these, right? So substance use in our first study that I presented is a control variable that wasn't sort of on the graphic that I shared. But we're trying to figure out a way, a way that it's more like theoretically integrated as something that's just so important, because we know that substance use among incarcerated populations is such an issue.
I'm going to have to run. Kylie can keep the meeting open, I guess, a couple of minutes longer if people have other questions. But I just want to offer, if it would be of interest, to have a conversation with us separately about the reentry study that we're in the process of doing, and perhaps, because I mean I was so full of ideas about how your review of what's been done makes the case for a new study that has all the right measures in it. And I imagine you might be thinking about those lines. So if you'd like to talk about that, kind of at our leisure, we would be really happy to. And I'm going to leave you to Kylie and Jim to kind of wrap things up so I can not be late to my next meeting.
Thank you. I appreciate that, and I'll definitely be in touch.
Great. Thanks so much.
All right, well, we are just at the end of our time, but just want to thank everyone so much for joining us today. And of course, thank you, Dr. Link, for sharing your important research with us, this really wonderful talk, and your expertise with the NJX community. We're really grateful to have you with us today. Thank you again, everyone. Take care, and we'll see you at the next seminar.